Right, I'm just trying to load this talk for you. Okay, I hope you can hear me for the second talk. I've been punished with 2 talks in a row. Thank you very much again for that introduction, Atul. And we're talking now, switching a little bit to talk about early lung disease and cystic fibrosis. This is something that I've been studying for many, many years. I was hoping I would never have to show one of the main slides from my PhD again, but I am going to show it. And that's because I'm very grateful for many of the people in London who supervised me during my PhD, including Professor John Price and Andy Bush and many others, and Janet Stocks, a study that was done through 5 centres in London. And this is where I developed my interest or expertise in infant pulmonary function testing. We used the raised volume test. And this is one of the main outcomes from my PhD, the identification that using these infant lung function tests, that babies with cystic fibrosis, soon after diagnosis, and this was a clinical diagnosis in London at the time, could have lower lung function. This was measured by forced expired volume in 0.4 second, as you can see on the y-axis. And these are healthy controls. Yes, we were able to sedate and study around 160 infants without cystic fibrosis, remarkably for this study. And these were children who had no prior lower respiratory illness, and those who'd had prior respiratory illness, because that was a common way of presenting before the screening era. So some of these changes could occur even within the first few months of life. But people have been looking at lung function in CF since the 1960s. This is Professor Peter Fillen, who actually published the first infant lung function study in CF, I think in 1968, remarkably. So there has been at least 3 decades of study of early lung disease in CF. So is that study still relevant? Certainly the advent of CFTR modulators would suggest perhaps it's not. We've got wonderful treatments now that are disease modifying. We can introduce them early on in life. And so why are we that concerned about what happens within the first couple of years of life? So I'm hopefully going to just try and explain why I think that's important. I think that infections occur early on in life. These are still common, even in the era of CFTR modulators, as I responded to the question previously. We know that changes occur in terms of outcomes. They have done for 2 or 3 generations. The outcomes for people with CF prior to the advent of CFTR modulators has improved. And some of that must have been related to early interventions. And also, we need to study early disease, because what we'd really like to do is to predict who's going to remain well and who needs those treatments most desperately, because they are, as we're all aware, expensive. And even Western countries post the COVID pandemic and the economic consequences may not be able to afford these sorts of medications. And there's a large proportion of people with CF in the world who won't have access to these because of their cost. So in 2004, I emigrated from London to Melbourne, and we joined forces with a team in Perth and established the Australian Respiratory Early Surveillance Team for Cystic Fibrosis. And at that time, what both centres were doing was fairly aggressive early surveillance. So both centres had screening programs in 2004. And so the children were being diagnosed early on in life, in the first few weeks of life. And they were recruited into the Resp program. And as well as having close phenotypic observation, we performed infant lung function tests, bronchoalveolar lavage at that point at 3 months of age, and then annually when children were well. And then we introduced CT scans of the chest. These were done annually initially, using limited slice CT scans. And subsequently, we moved to volumetric scans as the scanning technology improved, and as we iteratively were able to reduce the radiation dose associated with collecting CT data. So CF has now evolved into a fairly complicated program looking at predictors and clinical trials and endpoints and disease mechanisms. And I'm going to show some of the more recent data, trying to concentrate on data in the last couple of years and data that's pertaining to some of the longitudinal outcomes that are arising. So I want to show again this, because I think it's important. This is from the United States Cystic Fibrosis Data Registry. And these are lung function that you can see it starts at 6 years of age, because generally that's when children start performing their spirometry. And this is for subsequent cohorts from 1984 to 1988, right up to the most recent one in this figure, which was 2004 to 2008. And you can see that during this time, lung function, when first measured at age 6, seems to have been improving in these subsequent cohorts. And obviously, to improve at age 6, the changes that have occurred to confer that improvement must have occurred prior to the age of 6. And this therefore immediately shows that changes early on in life, and this is before screening became a big event in the US, some changes early on in life were impacting positively on lung function at age 6. These are also from the United States Data Registry, ending in 2013. And what they show, I'd like you to concentrate on this top line. These are from children who are at 6 years of age, and this is their median plotted each year from 1986 up to 2013. And so you can see the lung function, this is FEV1% predicted at age 6 in 1986, was sort of below the normal range. And this has increased iteratively throughout that time until in 2013, it's essentially normal. And I think perhaps because it's normalized, you don't find these data presented in the US registry anymore. But normal lung function of normal FEV1 doesn't necessarily mean that there are no changes within the lung. So at 6 years of age, in modern cohorts, CT scans show that around 70 to 80% of children actually have evidence of bronchiectasis at that time. So what about early disease in cystic fibrosis? And this is a very nice paper from Dutch van der Vanter in the States, who looked at all studies in the multi-system components of cystic fibrosis, which identified early disease and plotted when in the time life course those were first detected and the proportion of people that were affected. So for example, I'm going to come back to bronchiectasis in a second. If you just look at pancreatic dysfunction, because that's the most widely recognized, and those of you who see children nowadays will know that even at 3 or 4 weeks of age, they often have some impact on their absorption, and children have evidence of pancreatic dysfunction, which increases during the first year of life. Bronchiectasis has been shown to occur in infancy, and it's admittedly very mild, in about 30% of children. And this increases during the first 5 or 6 years of life. So I'd like you to consider bronchiectasis, because that is the end point of inflammatory and infective damage that results in scarring of the lungs. And I want to consider bronchiectasis in terms of screening in cystic fibrosis. So what are we doing with screening? And I'd also like to think of this in terms of CFTR modulators. At the moment, I would say that we're performing tertiary prevention. That is, that we are using treatments that aim to reduce the negative impact of established disease, so substitute bronchiectasis, by restoring function and reducing the disease-related complications of bronchiectasis. What we would like to do is to move towards secondary prevention, and I think we have in many centres moved towards this. So these are strategies to try and prevent and diagnose an existing disease in its very early stages and limited at that point so that it doesn't result in significant morbidity. But really the holy grail is primary prevention strategies. So we want to actually prevent any development of disease, and that means preventing the presence of bronchiectasis. The final aspect of screening that we often don't think about is quaternary prevention. And this term describes health activities that mitigate or avoid the unnecessary consequences of excessive interventions. And you're aware that we don't have at the moment good ways of prognosticating in CF. And so what we tend to do is use a whole armamentarium of treatment in a big majority of children. So many children may be being treated unnecessarily. So what about the longitudinal outcomes of early lung function? And the longitudinal data suggests that early infections are important in predicting where your lung function trajectory runs and what your lung function is like when first measured by spirometry at age 5 or 6. And what this graph shows is that early infection with Pseudomonas aeruginosa, Haemophilus influenzae, and Staph aureus all impact that early trajectory, so that children who've had infections with these organisms in the first few years of life has significantly lower lung function, even though it might be within the normal range when measured at school age. We've also learned over the last decade lots of lessons about this early bronchiectasis. I've mentioned that it can be present in infants in about 30% of cases. This can also occur in infants who are asymptomatic. Its prevalence increases in longitudinal studies through the preschool years, and it's progressive. We don't see in CF some reversing of this bronchiectasis when we first identify it. The progression is related to the presence of early respiratory inflammation, and early inflammation at 3 months of age has been shown to be associated with bronchiectasis in these children at 3 years of age. It's the strongest predictor of that. We do have surrogate opportunities using newer lung function tests, such as multiple breath washout. In our hands, we found this to have a very good positive predictive value, but not a wonderful negative predictive value for bronchiectasis. But we're certainly looking at ways of using this so that to minimize any radiation dose, because I'm not actually suggesting in this talk that using lung function, CTs as routine surveillance is an appropriate thing to do, but it's certainly something that has some utility in managing early CF patients. When we look at early infections in the bronchoalveolar lavage, and this is on standard culture, when we identify these organisms in isolation, we can see that there are certain pathogens that are associated with lower respiratory inflammation. And these are cross-sectional data now. You can see that the standard pathogens of Haemophilus influenzae, Pseudomonas aeruginosa, and Staph aureus are unsurprisingly all associated with early infection. But something we identified in this study, but we didn't really focus on much afterwards, was that when we identified Aspergillus species early on in CF, this was also associated with pulmonary inflammation. We thought that this was probably an epiphenomenon and that Aspergilli were present as a consequence of treatment of other organisms. These are more recent data showing the prevalence of infections in our arrest CF cohort now. And interestingly, you can see there has been a fall in prevalence of some of the standard organisms like Haemophilus and Staph aureus, but we have seen this increase in Aspergillus species over recent times, such that in more recent cohorts, we actually find that Aspergillus is one of the most common organisms that we identify in BAL, and even more common than some of the other organisms that we standardly associate with disease. This might be important, and we've shown in this particular study that having Aspergillus within the BAL is associated with subsequent poorer outcomes. And this is shown here in terms of structural changes on subsequent CT scan data over the ensuing 5 years of life. So if you had Aspergillus infections, the more time that this was identified within the lower respiratory tract, the more severe your CT total disease score was years later. And similarly, this was also shown for other findings on the CT, such as trapped gas and also bronchiectasis. Although Pseudomonas had a much more profound influence in bronchiectasis, Aspergillus seemed to be associated with peripheral mucus plugging identified on the CT scan. So our paper is one of the first that seems to suggest that Aspergilli may have a pathogenic role in early CF, which is very concerning given the recent changes in the epidemiology. So some data on Pseudomonas. This map doesn't show the bushfires that we've recently had in Victoria, but it does show where children in our service live who develop Pseudomonas or not. So these are children that live within the regions, and these are children that live within metropolitan Melbourne. And they're roughly evenly distributed in terms of number. What we did in this study was look at factors that were associated with the very first acquisition of Pseudomonas in the lower respiratory tract using bronchoalveolar lavage. And our surveillance showed that the first acquisition occurred in the second year of life, and that children in the metropolitan areas of Melbourne seem to be relatively protected in relation to the regional or more rural parts of the state. So these are, again, Kaplanmeier curves that highlight that. You can see here, these are the regional children, and you can see their survival curve is much worse. They have an increased likelihood of developing early bronchiectasis. And this is from a more recent publication, which looked following eradication of the Pseudomonas, which was successful in around 80% to 90% of individuals, monitoring these children over time. What happens in terms of recurrent Pseudomonas. And you can see again here that these children in the regional areas seem to have a significantly increased odds ratio for recurring Pseudomonas infection. And this sort of highlights the fact that there are geographic or climatic factors that seem to be associated with early infection that we haven't paid a lot of attention to. Similarly, our sister hospital in Perth has very similar early management practices for cystic fibrosis. But in our own Australian CF registry, later on in life, have much better outcomes in terms of lung function. And this is curious because our early data in the first few years of life show that in our cohort in Melbourne, children are much more likely to have evidence of infection within their BALs in the first few years of life. And this is a very interesting finding because those early infections are also associated with inflammation and other poorer disease outcomes. Again, there may be some significant geographical and environmental impacts beyond treatment differences that actually impact on our long-term outcomes in our centres around the world. So what about viruses? I mentioned that viruses potentially have an important role. This was a study that looked prospectively at viral infections in infants with CF over the first year of life. And we showed that viruses themselves were not associated with lower respiratory inflammation, but they were associated with the increased likelihood of acquiring CF pathogens within the lower respiratory tract. So those subsequently were associated with greater inflammation. So the role of viruses early on is not to cause more frequent exacerbations in people with CF. The exacerbation number seems to be similar to those without CF. They may be more severe, but there certainly is an interaction with viral infections and ensuing bacterial infection in the lower respiratory tract, which may subsequently be associated with poorer disease outcomes. So again, in longitudinal studies now, we've looked at the relative role of lower respiratory inflammation and its impact on structural lung disease at 6 years of age. And what we've shown in this paper is the cumulative inflammatory burden within the lower respiratory tract has a more profound and significant impacts on structural disease outcomes even than early infection. And this is important information because we don't at the moment target inflammation in early treatment of exacerbations. And there aren't really any decent anti-inflammatory treatments that have been used in CF. But we do need to consider inflammation as a specific target early on in life. Another factor that's been shown to be associated with inflammation are differences in mucus accumulation in the lungs of infants and young children with CF compared with children who don't have CF, who may have had a BAL for other causes, as identified in this publication by Esther et al. From our group. In this study, looking at BAL, they found that there was a difference in the mucin concentration and nature between CF and non-CF. In children with CF who had infections, this did not impact on the mucin nature, and so it looked like there was a constitutive difference in the mucin composition in CF. Figure C and D show scanning electron micrographs of mucin in healthy individuals and those with CF. And you can see that the structure of these mucin flakes is very different early on in CF. This is an immunohistofluorescence sample in health, and this is in CF, and it's stained for the mucins MUC5B and MUC5AC. And again, you can see that these mucins are distributed and structurally very different early on in CF. There's also an increase in these mucins in early CF. And interestingly, again, as we showed, these are associated with inflammation. And these are not the standard mucus that we have been recognizing in CF for some time, associated with the large airways. These are mucins that we think are probably located within the smaller airways, which is quite interesting because the earliest changes in CF are actually occurring in the small airways and not in the larger airways where we usually identify the inflammation and infection. Another aspect of these mucin flakes is that there's a potential there to treat them. These form gels which are fairly resistant to treatment, but this particular compound, DTD, has a reducing component or properties, and you can see compared with DNAs, which has no impact on these mucin gels, DTD completely clears them. So at the moment we're exploring reducing agent treatments that might impact on the early mucins that occur in CF. So a little bit about CTs. I'm not advocating that CTs be performed for routine surveillance, but having been part of a group that used routine surveillance, we felt it important to look at what the potential clinical utility of those CT scans might be that inform our practice moving forward. And so we asked our clinicians at annual review how they were interpreting the CT and particularly the findings of bronchiectasis, but also mucus plugging, and how that impacted on their treatment. Of course, the treatment interventions were not evidence-based, but many treatments in medicine are based on a sort of clinical judgment. And what we found is that the CT scans done early on in life were very commonly impacting on treatment changes, mainly in relation to the introduction of mucolytics, particularly recombinant DNase therapy. Occasionally, children were admitted because of the CT changes as well. And the number needed to investigate to be associated with the treatment change was 2.5. So for every 2.5 CT scans, there was a change in clinical practice. Is there another potential predictive role of CT scans? These are data that haven't quite yet been published, but are due to be published very soon. And these look at scores on CTs obtained at 5 years of age, and their association with subsequent lung function in the 10 or so years after that. And so what you can see here are at 5 years of age and subsequently lung function changes in people with CF. And this is the cohort of children who don't have mucus plugging on their CT scan. And these are children who do have mucus plugging at age 5 on their CT scan. And you can see they have slightly lower lung function and also more severe decline over time. And this is modeled here when we look at the baseline finding on the CT scan over the next 10 years of life. Those who have mucus plugging on the CT scan at age 5 have this increased decline in lung function that occurs later on. And this is pretty crucial because most children in the modern cohorts, in the modern era, maintain fairly normal and fairly decent lung function until around adolescence, and then there occurs this decline. So one of the things that we're looking at are, can we impact or intervene here at a much earlier point in time to actually attenuate this decline that occurs during adolescence. This is again showed here by the various scores on the CT scan. You can see that at age 5, bronchiectasis had some predictive value, but the most significant finding was mucus plugging. And we think that mucus plugging identified on the CT, which is often seen in the periphery and causes peripheral airway obstruction, which might be manifest as air trapping in these individuals, might reflect ongoing inflammation and active disease. And so this seems to have the greatest predictive value for changes that occur in lung function in the ensuing 5 to 10 years of life. So another question that's often asked in relation to Resp are how the data that have accumulated over the last 10 to 20 years have impacted on treatment. Well, obviously, to impact on treatment, we need more trials. It's exciting that there are increasingly a number of randomized controlled trials occurring early on in life. And Jane Davis, in the subsequent talk on modulators, I hope will be referring to some of these. But generally speaking, what the data seem to suggest to us, at least, is that the lack of reported symptoms isn't necessarily reassuring early on in life in CF, because such children can have significant structural changes that progress. They may have impacts on their subsequent spirometry when first measured at school age that aren't identified, and they may have ongoing inflammation, which we've shown cumulatively has subsequent impacts on structural changes later on in life. It would suggest that treating infections irrespective of symptoms might be important if those infections impact on early inflammation. It would suggest that other organisms other than Pseudomonas, for example, Aspergillus or Staph aureus and Haemophilus, need better antibiotic treatment regimes to try and eradicate or treat them. It also suggests that we might need to improve our surveillance for infection and inflammation. I'll come back to that in a second. We perhaps need to look for resolution of inflammation when we've treated exacerbations. We might need to introduce mucolytics earlier. Obviously, we've mentioned about viral infections and their potential heralding of earlier acquisition of CF pathogens, but certainly all our children need to be immunized with influenza, and we need to be targeting 98 to 100% immunization success of our cohorts. In terms of supportive care, these are things that are done in all CF centres, but there are things that we've just tightened up early on in life, even compared with later on in life, ensuring that the good practices are done with written management plans, that we have scheduled reviews, that we have unscheduled reviews. Perhaps one of the things that we need to do is enhance our communication with families. And I said I would come back to this. The prospective study that we conducted looking for viruses in children involved calling families up on a weekly basis. Now, our practice is to see children monthly during the first few months of life, and then 2 monthly, and then right up to a year. During this study, we contacted families every week, and we were quite surprised to find that on a number of occasions, children had symptoms that would not have otherwise been reported to us if we hadn't been contacting families on this frequent basis. And so I suppose one of the benefits of moving to online or telehealth patient surveillance, as we've done now in our service, and I'm sure many of you have done, is utilizing perhaps different models or care models as opposed to sort of standard, routine, regular outpatient clinics that perhaps are not the best way of picking up early signs of exacerbations that we need to intervene to try and arrest some of the changes in terms of the structural changes that I've identified. So with a little good news story, I've mentioned before that there has been this improvement, secular change over the last few decades when we've looked at lower respiratory inflammation, manifest here as free neutrophil elastase within the BAL, because that is the finding at 3 months of age that was associated with subsequent bronchiectasis. We found that in the first 5 years compared with the second 5 years, there was much greater inflammation in the early BAL at 3 months, 1 year, and 3 years of age. So this is without the advent of CFTR modulators. This does seem to be the secular ongoing improvement in early life. And we're hoping that this continuously means that there are better outcomes for people with CF. But again, normal lung function at age 6 doesn't mean that we have completed our job and that we can move on to different and better problems. So to conclude, lung disease, including structural changes, are common in infants and preschool children. Early intervention studies are essential to prevent structural changes and move the screening paradigm to primary prevention. We need to think about different ways of conducting our trials because we have very few infants around the world and lots of programmed activities and interventions that we want to study. So perhaps what we do need to move are multinational platform and adaptive trials, much like the cancer groups have used for decades to improve outcomes with childhood leukemia. Can we target those at greater risk of progression in early life? That's our main focus at the moment. There do seem to be some early predictors. We need to look to strengthen those to see whether or not we can minimize side effects and optimize risk-benefit ratios for early treatment in CF. So just to thank all the members of the team in Melbourne. I don't think I've done justice to all the number of people that contributed to the papers. Once again, been a pleasure talking to you, and welcome any questions. And I hope I've been controversial enough to elicit some angry responses as well. I can cope with those too. Thank you very much for listening.
Thank you very much, Sarath, for the excellent overview of and explaining in very simply all of the detailed work which has gone through. So as you have said, we start with the first controversial question from Tim Mucin. Do you know if bronchoscopy and infant lung function testing under general anesthesia 3 times in first 2 years could have an impact on inflammation and long-term outcome versus as clinically indicated?
Well, I tell you that there is a large study which was it was called the Australian CF BAL study, and the PI of that was Claire Wainwright, and she published some great data in the mid-2000s, I think, where they randomized children to undergo BAL surveillance versus routine surveillance with oropharyngeal swabs. The interventions were predicated on treatment of Pseudomonas, and the conclusion from that study was that there was no difference in outcomes at age 6 years of age and between those two groups. And the conclusion was that BAL surveillance wasn't indicated. But if you look at those data very carefully, and my interpretation of that was that both treatment arms actually failed, in that 70 to 80% of that cohort had very significant structural changes with severe or significant bronchiectasis at 6 or 7 years of age. So the treatment that was used in that study, which was targeting Pseudomonas in the way that they did, and our center was included in that, was not effective in preventing bronchiectasis. And so that highlights again the need to look at other organisms early in life. And the difference between Pseudomonas and some of the other organisms like Staphylococcus aureus is that Staph aureus is actually routinely present in the upper airway. When you get a cough swab that grows Staph aureus, it doesn't correlate with whether or not you've got Staph aureus in the lower airway, and it doesn't correlate whether or not you have inflammation within the lower airway. So when you identify Staph aureus within the lower respiratory tract on a BAL, it is associated with pulmonary inflammation. So what we need to do now are intervention studies to try and impact on that association, or even the pathogenic nature of Staph, for example, and other organisms. So I think there's a difference in surveillance for looking at oral organisms as a different to Pseudomonas, which we think normally arrives in the lower respiratory tract, having transited from the sinuses and the upper respiratory tract. So if I saw an upper airway sample that had Pseudomonas, I would want to treat that individual. But if I saw an upper airway sample in an asymptomatic child that had Staph aureus, I wouldn't necessarily want to treat that child.
Thank you very much, Sarath. Two questions, and then I think we ask people to come back next year when you would be in London. With the advent of CF modulator treatment and increased survival in CF, would you consider switching to MRI scan rather than CT?
Yeah, I'm not advocating doing surveillance CTs. I think there's I think we're looking at ways of using LCI to provide that prognostication that we think that a CT scan at age 5 might perform. The CT scan at age 5 can be done without a general anesthetic, and I think also with modern scanners it can be done with radiation doses that are very safe. So I'm not advocating doing routine longitudinal surveillance, but certainly what I think might be useful in registries, now that we know that we can normalize lung function, is at age 6, include in our registries another component that assesses how well we're doing in terms of the modern era of early lung disease. So if that's incorporating an LCI, and we're trying to prevent an elevated LCI at age 6, I'm happy with that. If it includes a measure of bronchiectasis or a CT score at age 6, and our next era is about normalizing that, then I'm happy with that. I think probably it's easier for people around the world to use a lung function outcome like LCI, but I do think we do need a disease outcome at age 6 that reflects the fact that there is an ongoing process here that we need to impact on.
And the last question, Sarath, do you do induced sputum?
Yes, we do induced sputum. We've done that in infants and published on that. I have to say that infants don't like it, and nor do our physios that we're doing the technique. But when we've looked at it, we have identified that the cultures on BAL and on induced sputum, even in infants, correlate very well. We often didn't have enough sample in the induced sputum to look at inflammatory indices. But I think there is a role for induced sputum. And one of the things that we're doing at the moment is trying to substitute early BALs for early induced sputum sampling in the first few years of life as a routine in our service.
Thank you very much, Sarath. And thank you again for joining from Melbourne.
You're most welcome. Thank you very much, and all the best.
Thank you. Stay safe. Now,